Hello, Don here. Welcome to Podiatry Practice Mastery. I'm going to actually talk about 2 days here. These are 2 half days that we had kind of near the end of the year here. So I'm going to go over first the most valuable patients for both of these days, and then we'll kind of get into it. The first patient was a most valuable patient. He was a 58-year-old man. He had bilateral heel pain, and he had bilateral equinus. He was from the Azores, and so I don't know if you guys know much about the Azores, but they speak kind of Portuguese, but different than Brazilian. So I speak Brazilian Portuguese. This guy spoke Portuguese, and they love codfish. So I was talking to him about a special codfish. So if you like codfish, let me know. But it's called Gomes de Sá, which is, I'm probably pronouncing it wrong. But anyway, it's codfish and potatoes and a lot of olives and stuff like that. So we were talking about that. But I think that just even goes to say, I think something that is really important for when we're talking to patients, if we can find some type of common connection, building that rapport, building that trust really helps to take things a lot quicker and increase acceptance and the recommendations that we have. I find a lot of times if we're always in a rush and we don't take that time to connect, it doesn't really work as well. So I like to really spend this time connecting with patients, whatever kind of common ground that I can find. Every day there seems to be something. The reason he was the most valuable patient is because he got the Pelto special, which is a night splint, foam rolling, and morning stretch. So he got bilateral night splints. And then he did get an over-the-counter insert. As I mentioned before, I'm starting to do some over-the-counter ones. These are the Northwest brand. They're kind of like a carbon fiber shell with a top cover, and these can be easily modifiable. And then I kind of prepped him for possibly doing shockwave. I find a lot of times that these types of patients, I prep them. So I'm using a new system when talking to patients called Phase 1 and Phase 2. And basically Phase 1 are most things that insurance covers, like these things that you typically see. And then Phase 2 are the things that insurance doesn't cover, but usually are necessary for patients. And I think that explanation reduces a little bit of the friction, especially when you're talking about high cost types of treatments for them. And you say, we're not going to do it now, but I introduce it the first visit. So that was the first MVP patient. The other MVP patient, he had bilateral, actually a 31-year-old female. She was a physician's assistant. I had previously seen her in the past for peroneal tendinitis with shockwave, and she came in now with bilateral Achilles tendinitis. And so she had done well with the peroneal tendinitis with 3 sessions of shockwave. And so I think a lot of times what our precedent is what patients expect. And I think this is something good for us to know, because when I was doing less shockwave in the past, for example, 3 sessions, people kind of get used to that, and I think that's something that's important. So, for example, in your practice, if some doctors are doing 3, others are doing 4, others are doing 6, or if you've done 3 in the past, patients tend to expect that. So I kind of kept it at 3, and I said I now do 3 to 6, and we'll start at 3. And another thing is she previously paid $400 for bilateral, and now we're going to do $400 again. Usually it would be $500, but because she's had that before, I'm going to kind of stick with that. So she's going to do bilateral Achilles, and this was one of the second MVPs. Okay, let's go into some of the other patients. Another patient was a 35-year-old man, did an office visit, he had x-rays, and he had left lateral ankle pain and some instability, and I put him into a velocity brace. So a velocity is like a non-custom AFO, and he was able to get that. I'm going to see him back in a couple weeks to see how he's doing. So the DME was a good aspect to that. Next patient was a 52-year-old for a right partial nail avulsion. And just to repeat, for me, a nail avulsion is when there's no infection, and a paronychia is when there is an infection. So not all of mine are paronychias. Sometimes if I'm just removing the nail partially or totally, it's going to be a nail avulsion. Next was an 80-year-old man for a right plantar fasciitis. He's already feeling better, and he is number 4 out of 6. Next was a 58-year-old man. He had that was the one bilateral equinus that I was telling you in heel pain. That was other MVP. Next was a 69-year-old female. She had an x-ray. She had follow-up of her second metatarsal pain. That's feeling much better. So I think one area that is very helpful is x-rays. Even if they're feeling better, if we're looking at a follow-up for a stress fracture or a follow-up for foot pain, doing an x-ray or even doing x-rays or teaching your staff to do x-rays for all types of forefoot pain, so for example, metatarsalgia, even if it's a painful callus, I think doing an x-ray can be beneficial because you can see the bony prominence on that area. When I'm doing a callus, I tend to do a metallic marker on that area. Next was a 14-year-old little boy. He had left severs, and so I recommended to start. We did x-rays. My Pelto special was a night splint, foam rolling, and morning stretch, and I recommended the Thule heel cups with cushion, and I'm going to see him back in about 3 weeks, and if he's not better, the plan is going to be to do shockwave for him. I do have good success for shockwave for severs. Next was a 55-year-old man for right IPJ. He had some pain there in that area. He also had a diabetic foot exam I did, and did nails 1 to 5. And then we set him up for routine care with a nail tech in 3 months. So just kind of a nail patient. Next was a 63-year-old female. She's doing follow-up after 6 shockwaves. She is feeling 90% better. She had a little concern her orthotics were a little too short, and so I sent them back. So this is one of the issues that I have with my orthotics forward motion, is sometimes they can be a little too short. Patients, get a second pair, but I always take a picture and I send it back. So it's kind of a pain for that, but I'm not going to see them back for this, but I'm just going to have them exchanged out. The next was a 56-year-old female. She had a nail sample on the right, and she also on the left foot, she had ingrown, so she had a partial nail avulsion for that painful ingrown toenail. Next was a 17-year-old female. She had a right IPJ callus / wart. I did salicylic acid or lesion destruction. And then she had a bunion, and we did orthotic for her, I think, because of the bunion. So that's right. She had some FHL pain and then a bunion, and because of that, we did the orthotic for her. So she's going to be seen back in about 4 weeks to see how she's doing with that callus lesion destruction. So that was one of the previous days. I'm going to go back into this other day. This patient has, he's a hiker. Now this guy is kind of interesting. So he's a hiker. He really likes to hike. That's really part of his identity. He has a callus with a bony prominence underneath it. So we talked to him about Liposana, and I said, it's like you can put a pad on the outside, like a Dr. Jill's, or you can do padding on the inside. The benefit to the padding inside, it lasts 1 to 2 years. Patients love it, and it'll help you get back to your hiking. And so he actually wanted to do the Liposana. And then the patient just after that was a 77-year-old female. She had a painful 5th Met. And I said the same thing to her. She had fat pad atrophy, and she already had an orthotic. And I said, yeah, so this is Liposana. Patients like it, and it costs $1,500. And she accepted that. So I'm not sure if the first one, the 70-year-old one, the hiker, is going to do it, but definitely the 77-year-old will be doing it. And it was interesting. So I think a lot of times when we're offering these to patients, we are kind of almost like apologetic, where a lot of times the patients, they are really not concerned. They just want to get better. And this is something that I've been working on. It's called selling the vacation. I don't know if you've heard about this term, but basically you're trying to sell them or explain to them what the best outcome is. And so once you kind of explain what they have, you give them a diagnosis, you kind of talk about kind of how it's been affecting their life. And then one easy way to say this is like, okay, well, what happens if we were meeting here 3 months from now and you didn't have this pain any longer, you didn't have this situation? How would that make you feel? Like, what could you do that you can't do now? And like this one woman, I'd be able to walk without pain. I could wear shoes that I want. Or the other guy, I could do hiking. I think selling that vacation is something that we're really not used to asking. That one additional question, I think, is a question that goes a long way when working with patients, because you are what's called selling the vacation. So what the term comes from is, if someone wants to go, like I want to go from here to Brazil, the vacation I want is the all-inclusive resort in Brazil. I don't want to talk about having to get my tickets, the 24 hours of flights, the hotel that I'm to stay in when I get there, on the way, the possible missed flight, the bad food, the lack of sleep from sleeping, or not sleeping on the airplane. So those are all the things you have to get through. But what you want to sell is, okay, you're going to be in a wonderful all-inclusive resort in Brazil. And that's what we are actually telling patients that's possible, and that's what they want. What they don't want orthotics and shockwave and Liposana and all these other things. They just want pain relief, and that is what it means to be selling the vacation. Okay. Next patient was a patient for bilateral onycholysis. She had a wavy nail. So what I did with this one is when there is onycholysis and like only a third of the nail or a fourth of the nail is attached, I will trim it all the way back, grind it down with a Dremel, and then I will do Onifix on there. The other option was to pull it off and then do Onifix in 3 to 4 months. I'm going to see her back in 6 months. Now, I do not regularly Dremel, so I really never talk about Dremeling. The only time I Dremel is when I am doing like an Onifix or a Carry Flex when I need to get that nail down. Otherwise, I just use a regular nail nipper on the nail days. Next was a 69-year-old. This was a fungus follow-up, and they were seeing back in 3 months. And I don't think they really took the medication. They got the fungal kit today, which would be the UV light shoe spray and the biotin. Next was a Swift, and this was an unfortunate patient. This was a little 16-year-old girl she brought in with her friend. Now, this friend, he's kind of been a friend of mine for a long time. Actually, about 20 years when I started, maybe 15 years when I started in practice. I used to be in BNI. BNI is Business Networking International, and this was a fun group to be in, but I didn't really get any business for 15 years. But now I think as all of us are getting a little bit older, I'm seeing more patients now 15 years later than I ever was seeing before. But I saw his daughter, and she had a wart, and I gave the options of like, okay, we can do Cantharidin, we can or do Swift, and they opted for Swift. But the problem was she just cried way too much. She cried a lot. I wasn't even that high in terms of the energy. And so this is one that I think we're going to have to pivot and treat her with the Cantharidin. I think that's going to work much better for her. But this was the one patient that really just cried. And it wasn't even that high. I was thinking maybe next time I should go a little bit lower, starting out to see what she can tolerate. Next was a 10-year-old little boy. He had kind of like a cavus foot, and no, it couldn't have been 10. It had to be older. Must have been like a much older. But a cavus. We did they did dress inserts, frustra elevatus, and we talked about correctos. So we did the half inserts to do the correctos for this. This patient had some like hammer toe starting. Next patient was a 73-year-old. This patient had ball of foot pain with pressure and also some Raynaud's or chilblains. And so this one I just trimmed down the callus, and I would talk to them about these pain creams that I'm using now. Next patient was I did an over-the-counter insert, trimmed the callus. This is the one, or just a patient that had some callus pain. So I think these simple callus patients, I think these are going to be easy ones to do these over-the-counter inserts to start out with, these kind of the Northwest brand that I'm using. Next was a fungus follow-up. I started their med, and they did the Pelto special for the UV light shoe spray and things like that. Next was a 60-year-old with the number 4 out of 6 for Achilles tendon. They're already starting to feel better at shockwave 4. Next was a 63-year-old man for bilateral warts, did Cantharidin. Next one was a 38-year-old female, did an IND. And then the last was a 56-year-old for a 6 out of 6 for Achilles. And patient is doing much better at this time. And I think this patient requested to do physical therapy. So this was the day, kind of a hodgepodge of little different types of treatments. But hope you guys found it beneficial. If you want to learn more, go to Podiatry Practice Mastery. Happy to go over my $1 million blueprint, which kind of goes over a lot of these things, how to get your practice to the $1 million mark and beyond.